Good morning, everybody. A very warm welcome to all of you on behalf of Azim Premji University. We are delighted to be presenting today's program in our series of public lectures. This is perhaps the 80th or so, and we started this about 10 years ago. I know all of you have come here because you are invested in the development of the country and because you are well-wishers of the Azim Premji University. Thank you very much. Public lectures are one of the ways by which the Azim Premji Foundation tries to foster its vision of a just, equitable, humane, and sustainable society. We invite public intellectuals like Dr. Swaminathan across various spheres of life to come and speak at our platform. In the past, we have hosted, among others, Dr. Manjul Bhargava, Fields Medal winner, Dr. Joseph Stiglitz, the Nobel laureate, and many others. Soon after this introduction, Dr. Soumya Swaminathan will deliver her talk for about 50 minutes. My colleague Amalendu, a member of faculty at our university, will then engage the speaker in a short Q&A, and we will have time for audience questions. We hope to close at 12:30. A brief introduction to the speaker. Dr. Soumya Swaminathan's CV was part of the invitation, so I won't read it, but I'll just pick a couple of highlights. She's a rare combination of a doctor-scientist, a pediatrician known for her research on tuberculosis and HIV, a global Indian who has done the country proud, having served as the chief scientist of the World Health Organization during the most challenging COVID years. She is a fellow of the National Academy of Sciences and the Indian Academy of Sciences and is now investing her energies in the MS Swaminathan Research Foundation. Dr. Swaminathan will deliver her talk on food and health. Are we on the right track? The topic itself, food and health, could have been called father and daughter, probably as aptly. Please join me in welcoming Dr. Soumya Swaminathan.
Good morning, everyone, and thanks for coming. And thank you so much, Professor Sudesh, for that very kind introduction. It's lovely to be back at the BIC again. This is my third talk or visit here. The first one was for the first Girish Karnad Memorial Lecture. That was right during the pandemic, actually, but we did have it in person. And then was a panel discussion on COVID and, how did Karnataka respond, how did the country respond, what's going on now, etc. That was very interesting to get. We had the Commissioner of Health, but we also had Dr. Prashant, who works in the tribal areas and brought that perspective. So today, the topic is food and health, which has become now my passion and interest after having been for a long time in biomedical research looking at tuberculosis, infectious diseases basically. I worked a lot on HIV, the interaction between TB and HIV, and noticed how nutrition was so important, really, even though these are infectious diseases caused by bacteria or by virus, the effect it has on the body and how an individual responds. A lot of it is based on your nutrition, which in turn impacts, your immunity. And right from the beginning of my research career, if you live in India, you can't help encountering malnutrition in all its forms. But as a pediatrician, I was most interested in young children, and particularly children who live in tribal areas as well as those who are in urban, maybe low-income environments, which are not so good for either nutrition or for health. And then having been through the pandemic most recently as the chief scientist, as well as looking at the health data and statistics from around the world that the WHO compiles, I was struck by the fact that our health is determined not so much by our access to a doctor or a health facility, which is what one thinks about. When you think about health care, you think about a doctor or a health facility or getting some treatment. But our health is really determined by all of the things around us, what are called the social and environmental and economic and commercial determinants of health. Or you can even talk about it as risk factors or determinants. And only 20% of your health outcomes are determined by access. Of course, access to health is very important. And so people who don't have access to health care or quality health care do suffer. But that's only when you fall sick. So most of our life is about preventing illness and sickness, or you can say promoting health. And therefore, even when you think about our ministries of health and what they do, not just in India but around the world, they should be called ministries of illness or ministries of disease, because they are focused on identifying and treating people who've fallen sick. They are not ministries of health. A ministry of health would be looking at how to keep people healthy. That's what public health should be about. But we are far from there. So yesterday I was talking to a group of lawyers. There's a conference called the Law Asia Conference that's happening here at the other end of town. These are lawyers from all over Asia, and I was talking to them about climate change, public health, and equity, and how climate change is really going to is impacting all aspects of our life, how public health really needs to respond, and how equity really plays a very important role. So the other thing I really got a very, very close look at during the pandemic was equity. Of course, here we're talking about equity between countries. We all saw the inequities in access, right from masks. At the beginning of the pandemic, there were countries that had no access to protective equipment. They were making up things. People were putting on garbage bags and using whatever they had handy to protect themselves, whereas other countries had full space suits for their healthcare workers. We saw inequities in access to oxygen, to a lot of health products. And then, of course, when the vaccines were developed, which itself was a miracle to have vaccines developed in 11 months of the identification of a new virus, never been done before, and it was only possible because there was a concerted and collaborative effort by the scientists around the world with a lot of funding, over $100 billion just put into development of vaccines alone, mainly by high-income countries. A lot of companies also investing. People stopped doing whatever they were doing, and all scientists started working on COVID. So it is possible for science to find solutions actually to our problems that face humanity today. It's not impossible at all. If you put the mind to it, if there is resourcing, and if there is the right kind of mission approach where scientists of all disciplines come together to try to solve one problem. The moon mission is often cited as being an example. The first, when Kennedy said that he was launching that, it was essentially a challenge for humanity, a technological challenge which was overcome. And in the process, so much technology was created. That's what happened. In the process of making vaccines, we now know about the mRNA, the power of mRNA technology, not only to make more vaccines, new vaccines, but also to develop a host of other products. But what we did see, which was not the bright side of it, was the hoarding of vaccines by a few countries, the reluctance to share, and also the reluctance or the refusal to share intellectual property and the technology knowledge, which some companies had access to. And the worst part of it is that the companies that had access to that technology, let's take mRNA for example, was all funded by taxpayer money. So it wasn't that the companies had invested. It was the NIH who had invested over a long period of time, or other governments, in academic labs in universities and created the technology which was then given away to the private sector to do what they like with it. So I think the whole model of R&D is also flawed. Now I'm just digressing a bit from this topic that I'll come to in a minute, just to give you a little bit of background on global health, public health, and the issues of equity, particularly as they relate to public goods, what we call as a global public good, or a public good is something that's good for everyone, that should be equally available to everybody. So, for example, clean air or clean water or a vaccine that prevents disease, these are public goods that everyone should have access to, right, regardless of the ability to pay. And these are things also that government invests in, that public money is put into. And so it should never get privatized, commercialized to the point where some companies make a lot of money. So this is not only relevant for vaccines for COVID, but it's relevant for everything. Now we want technologies to solve our climate problem, global warming problem. We need affordable technologies that can help us both mitigate and adapt to global warming. But again, if those technologies, are in the hands of a few, then it becomes challenging for low-income countries to move fast enough, considering the fact that we will bear the brunt of the impacts of climate change, even though we haven't contributed as much. Now, to get back to this topic, where we'll talk a little bit about nutrition and food, and I think it's a rhetorical question: are we on the right track? But before I get into my talk, the idea was that we do a little bit of a audience quiz here. So could you all take out your phones and get this? This is the menti.com, this QR code. And if you can download Menti, then what we'll do is we'll try and answer a few questions before we get started. Okay. So about, very good, 2/3 of you think you have a healthy diet. You should have had a maybe option. Okay, we'll go to the next one. How often do you waste food? Every day when I eat out, when there's vegetables on my plate, if I don't have non-veg. These questions were designed by a young colleague of mine. So, one option less is coming? We don't waste food is missing. Okay, but a lot of people waste food when we eat out. Every day also. People are wasting food every day. Okay, it's good that people are honest here. Okay, how many of you look at food labels before you buy something or before you eat it? That's good. A lot of people are looking at food labels. Of course, in our restaurants and all, many times we don't get labeling, but at least in the supermarket, in the packets, you get labeling. But abroad now, even in restaurants and even in the Starbucks, in fact, it's very horrifying if you go into Starbucks and you see how much your coffee, how many calories your coffee has, I often then walk away saying, okay, I think I won't have this coffee if it's going to give me 350 or 400 calories. Okay, so a lot of people looking at food labels. And what are the main things that you would look at in the food label? I think there should be some options there. Calories, fat, protein, sugar. Yeah. Brand. Okay. Great. Preservatives, expiry date, palm oil, taste enhancers, ingredients, composition. Okay, excellent. But calories, fat, and sugar, clearly everybody is interested in that. But it's good that people are looking also at things like expiry date, at maida, at added chemicals, refined flour. I don't see trans fats, but people are looking at fat percentage, refined sugar, etc. Okay. Now, this is more for us to have some behavioral change options, like what kind of campaigns do you think would affect you to change your food habits? We've got so many celebrities selling so many products now on television. Is that really influencing you, to buy that product? So these are limited options, I think, but hoardings, apps. So maybe later in the discussion we can talk about, are there ways of doing campaigns for healthier eating? But YouTube seems to be, and Instagram, I guess. An app, okay, many people think an app on the phone might help. Not so many think celebrities and influencers. So all those celebrities were getting paid quite a lot for advertising things. They should be aware. So here's something about causes of death, in the sense, what do the majority of people die of? And I don't know if you're all familiar with these terms, non-communicable diseases, which are things like heart disease, stroke, dementia, cancer, cardiovascular disease, heart attacks. And infectious diseases, okay, but infectious diseases are still not so rare. So malaria, HIV, TB kill a lot of people. As you know, COVID killed a lot of people. Dengue is not so much a killer, but yes, it can also result. But I think you're getting the proportions right. And as we get into an aging population, then certainly non-communicable diseases become much more common. But unfortunately, in countries like India, we still have both. And we have a rising burden of injuries and accidents. Road traffic injuries is huge. Last year, we had more deaths due to road traffic injuries than the year before. 2020 was the only unusual year because, of course, of the lockdowns. That was a dramatic drop in road traffic fatalities, but back again, 21, 22, and going up. So as our road and infrastructure expands, unfortunately, we're not paying enough attention to safety. So I think this is quite a good, maybe infectious diseases should be a little bit higher, but these are the three major causes of deaths. Okay, I think I already answered this question. Do you have a healthy diet? Wasn't this the first question? Okay, a lot of people here, you think you have a healthy diet, and maybe we also have choices because we know that affordability and access are important. Oh, but a lot of people are acknowledging that they don't think they have a healthy diet for whatever reason. Maybe we can explore in the discussion why, what is stopping you from having a healthy diet if you're aware of the fact that you don't have a healthy diet. Okay. So I think that was a quick, we go back to the presentation. Great, thank you all very much for answering those questions, and I think it's opened up some discussion points for us that we can talk about later. So you're all aware of the Sustainable Development Goals. We're supposed to achieve them by 2030. Now SDG 2 is zero hunger, and if you look at the targets, it has 5 targets. Universal access to safe and nutritious food, ending all forms of malnutrition, double the productivity and income of small-scale food producers, sustainable food production, resilient agricultural practices, very important, and then maintaining the genetic diversity in food production. So, there are thousands and thousands of edible species, I think some 8,000 or so edible plant species that people have eaten from the beginning of time. But if you look at what we eat today, there are 3 species, rice, wheat, and maize, which make up about 70% of the cereals that are grown and eaten around the world. So, from thousands of species, now we've come down to a handful that are grown in large volumes. So we are losing that diversity, what is called agrobiodiversity and genetic diversity, and that's very bad for us because if something happens to these plants we have today, they are such limited breeds, then they can all be wiped out immediately. So the genetic diversity in food actually helps them to also retain that vigor and the crossbreeding that happens. And also there are many of those land races which have a lot of nutritional properties which rice, wheat, and maize don't have. So those are the sub-targets of SDG 2. And then there are 3 others, 2A, 2B, and 2C, which is investing in rural infrastructure, agricultural research, technology, and gene banks. And I don't know how many of you know about the Svalbard Gene Bank, which is in Norway, which was, my father had something to do with setting that up. And it was done there because, it's below the, it's in the Arctic ice cap. Unfortunately, now with Arctic ice cap also melting, that seed bank, which was supposed to last forever and be in a place, where seeds from around the world are preserved for posterity, even that may be at risk. So you have to go down into a cave, which is deep under the ice. So gene banks and seed banks are the only ways now today to preserve that diversity we have. Then prevent agricultural trade restrictions, market distortions, and export subsidies. This is something that India keeps fighting for at the World Trade Organization. And then ensuring stable food commodity markets and timely access to information. Now, if you look at, we're halfway through the SDGs, so started in 2016 and supposed to end in 2030, so we're exactly at the midpoint. The pandemic, of course, set back the world quite a bit. And so if you look at India's performance, we are 112th out of 166 countries, so not doing that great. And then there's you can see on that wheel that you have some SDGs on which we may be doing better, but a majority of them, we're not doing that well. And in fact, there's been backsliding in some of them. If you look at the red arrows that are pointing down, reduced inequalities, that's number 10. That's actually, there's been backsliding, which means there's been increase in inequalities. And that's measured by something called the Gini index. And then also life on the land, we're not doing well on that. The only ones that we're doing okay in is, the climate action is also not satisfactory. So in 7 years, we have a lot of catch-up and acceleration. So again, this is a very simple slide to say that when we talk about, if you hear the word malnutrition, it can mean both extremes. Undernutrition, which is underweight, which is low weight for age, stunting, which is low height for age, and wasting, as well as micronutrient deficiencies, which can occur with both under and overnutrition. And in overnutrition, you have categories like overweight, and then beyond 25 BMI, then it would be obesity and so on. So that's how the standard classification is. Now, of course, both are harmful, but stunting in particular, which happens in early childhood. So the maximum growth of a baby, especially the brain development, occurs in the first 5 years, but particularly in the first 1,000 days of life. The first 1,000 days starting from conception and the first 2 years of life. So that is a very critical period for both, especially for brain and cognitive development, but also for physical development. So your height when you're 2 years of age determines your final height. And so anything you do after that will not have the kind of impact that you might want to see. So if you can start feeding up a baby or a child once they get into school, let's say they're very malnourished, that child will be permanently stunted because height is not going to improve. And in most countries of the world, as they develop, you see a secular increase in height. Every generation gets taller than the previous one. And even people with our genetic makeup, when they live in other countries, you can see that the children actually come out much taller. But in our country, there's no secular increase in height, or it's insignificant. And we still have a very high proportion of stunting. Around 35% of children, according to the latest NFHS 5 data, are stunted. And it means not only that they are physically short, that maybe you can live with, but there's cognitive impairment, which means that you're really talking about the human capital of the next generation, which is being impacted because of malnutrition in the early years of life, pregnancy and the first 2 years. So the first 1,000 days and the first 5 years are very important. So again, we come back to this communicable, non-communicable, and we were talking about which is more common. So in blue, you see what are called the non-communicable diseases, and of course diabetes and strokes and chronic obstructive pulmonary disease, COPD, ischemic heart disease, which is heart disease, heart attacks, all of that is causing a lot of the deaths. And as we live longer, these are going to go up. But you'll also see in red, the infectious and neonatal disorders are not necessarily all infectious, but the early newborn and deaths which occur within the first 30 days of life, maybe because of infection, could be because the baby is born very small, and could be also because of not having proper care during delivery and right after that. And then you have diarrheal diseases, lower respiratory infections, and tuberculosis still accounting for, even though we've reduced diarrheal diseases a lot, but we still have, you can see the number of mostly children, but also the very elderly who die of pneumonias. Now, this was a trial, a study rather, that was done, funded by the ICMR, the Indian Council of Medical Research, was done over 15 years, because large study where all the states of India were actually sampled, I guess, except Jammu and Kashmir, which is blank, for the prevalence of non-communicable diseases. It was called the INDIAB study. So mainly it was diabetes, but they did look at all these other things. So what is, firstly on this chart here, you see the numbers in millions. 101 million people with diabetes, another 136 million with pre-diabetes. And if you look at hypertension, 315 million. So we're talking about 20-25% of the population, and adult population is like a quarter of the adult population. Abdominal obesity. So this is a peculiar form of obesity where there's more fat in the abdominal visceral region, so that your waist circumference increases, even though the rest of your body may be thin. And this is very peculiar for South Asians, where the fat accumulates in the abdomen. So that is huge also. And then you have the hypercholesterolemia and things like that, which is, goes along with these other problems. So all very, very substantial and significant. Now, if you look at the maps of India on the right, the one on top actually shows you the prevalence of diabetes, and as you can see, the red will be the highest, that is more than 10%. So national average for diabetes was, and this was in people over the age of 15, was 11%. So 11% was a national average, but you can see the differences. Southern states considered to be more developed, higher prevalence of diabetes, highest in Kerala, Tamil Nadu, Goa, Punjab, 30%. 30% of people are diabetic. Then you find there are, as you go up north, then maybe it's getting less. Uttar Pradesh, okay, you might feel very happy that Uttar Pradesh has such a low prevalence of diabetes. It's only less than 5%. So they're doing something very good. But if you look at this, below, the map below, this talks about something called pre-diabetes, that you have certain markers in your blood, and your blood sugar is in a range, and your HbA1c is in a range, which we call pre-diabetes. Majority of these people are going to progress to diabetes. It's a matter of time, unless you take preventive action. So if you can detect yourself when you have pre-diabetes, and you really put in some changes in your diet and your physical activity patterns and all, you can probably prevent yourself from going into a diabetic state. There are also some medicines which help. But if you don't do that, then over a period of the next 4 to 5 years, you'll become diabetic. So the same states which we feel happy don't have so much diabetes. If you look at the graph below, the map below, they're the same states which have a lot of people who are pre-diabetic. So it's a question of time, and I think it's related again to human development indicators. We know that in the South, income levels are more, literacy rates are more, housing, sanitation, all these things are better. We've dealt with communicable diseases. So Kerala, for example, went into this epidemiological transition way back in the 1980s, when nobody was even paying attention, And therefore, today we find ourselves in a situation where we have a huge burden and we haven't paid attention. Health ministries were not paying attention to that. They were focusing on communicable diseases and maternal and child. Those were the big focus areas during the MDG era, which was 2000 to 2015. And we made progress, for sure, in those areas, but at the same time, we had a blind spot. So this is where we are today, but we still have, I think, a window of opportunity, at least in those states which are yellow and green, in this, in the pre-diabetes map, or no, if you take the pre-diabetes map, those states which are in red, which are still in yellow or green on top, we could intervene now and make a difference so that we don't have the same situation happening there. Now, if you talk about risk factors for death, we talked about mortality, right? And this is one way actually of it's not to be morbid, but it's a way of understanding your burden of disease. You know, when you understand what people are dying of in a particular area, and this is why the figures, even during the pandemic, were so important to have accurate reporting of death, whether it's due to COVID or due to something else. What is the excess mortality that was happening during that time? So these are the risk factors. And if you look at risk factors, right on top, you'll find, of course, men and women slightly different, but dietary risks are right up there, right? So second and third in terms of the risk factors. So our diet is what is actually determining, you know, our reason for dying. Could be through a variety of pathways. Then high systolic blood pressure. I showed you that we have about a quarter of our adults in India, for example, with hypertension. It's true for many other countries. And because it's asymptomatic, you don't have any symptoms of high blood pressure. Unless you're testing yourself, you will never know till you'll end up with a complication. You know, so it's not true that everybody with high blood pressure gets headaches. And you might end up many years later finding that you have kidney problems or kidney failure, and then you find out it was all because of uncontrolled high BP. So unless people test, they won't know. Then I want you to notice also air pollution, which is up there at number 4. So even though, you know, 95% of us are living in cities or places in the world which do not meet the WHO standards for air quality, and India is particularly bad for air quality, air pollution, both because of household. We still have indoor air pollution. You know, a lot of women in rural India in particular still using biomass. Even though they may have an LPG cylinder in the house, if you actually see what they do, they use the LPG cylinder very sparingly because it's expensive, and they still use wood or other biomass for like heating water or things like that. So it's still being exposed to indoor air pollution. Plus we of course all see what the outdoor air pollution levels are like, but it's a huge risk factor for our health, and it's something that everybody is exposed to, and you can't really escape from it. Then, you know, you see the other risk factors like, okay, high body mass index, so if you're overweight, high cholesterol, alcohol, malnutrition. Then there are occupational risks, unsafe sex, particularly for women, low physical activity, and other environmental and occupational risks. And again, occupational health is something that we don't pay a lot of attention to, but whether it's a software setting, whether, you know, you're sitting at your computer all day, or whether you're working in a hazardous factory, or whether you're a miner who's working with and exposed to silica dust, or whether you're a fisherwoman who is constantly having to peel prawns and, you know, have your fingers, or a salt pan worker who's exposed to the hot sun and salt all the time. Every occupation has its own risks, and I think that's not something that's very well understood, or we don't take the necessary precautions. Now again, how do we make this link? We said we looked at the top risk factors, we looked at the top causes of death, the link between non-communicable diseases and diet. So the top risk factors here are a diet low in whole grains and a diet which is high in sodium. So probably the number 1 will be sodium, too much salt. And we're supposed to take 5 grams or less of salt in a day. And the average, I think, in India is about 8 to 9 grams, and quite often it's more than that. And the more processed and ultra-processed food you eat, the more salt, hidden salt there will be, and also a lot of hidden sugar. So, and low in whole grains, so that means what? We're eating polished wheat, you know, polished rice, maida, and things like that. Anything which is white in color, they say, is bad for health. A diet low in fruits, vegetables, nuts, seeds, low in fiber, low in omega-3 fatty acids, low in legumes, high in trans fats. So many countries have now banned trans fats. In India, I think we have an upper limit of 2% or something. Trans fats get formed when you reuse the oil for cooking. So a lot of people, you know, you fry and then again next day you're using the same oil. That generates a lot of trans fats. So that's very, very bad for the health. Diet high in sugar-sweetened beverages, low in calcium, low in milk, or high in red meat, etc. So these are the major links, but you can just, you know, the top 3 or 4 are what is going to be important. And recently the World Bank looked at, you know, affordability of a healthy diet, because it's all very well to tell people you got to eat so much of fruits and vegetables, etc., but if you do look at that analysis, then the majority of Indians cannot afford a healthy diet. And I think this has been also studied by local groups and universities, that the average person cannot afford to eat what is referred a healthy diet, which you have the definition on the right side. So it must achieve all the nutrient adequacy and have sufficient diversity. So even though there is a relationship here between the cost and the GDP per capita, but if you look at the graph on the right-hand side, it is there is a correlation between people who cannot afford a healthy diet and the GDP per capita. So overall, we have this multiple challenges, or triple burden, you could call it. On the one hand, you have undernutrition in children, like we said, wasting, stunting, etc. There are figures there. You have undernutrition in women. It's going down. So NFHS 5 showed women 18%, men 16%, BMI less than 18.5, compared to a little bit higher in NFHS 4. But again, this will have a wide variability between states. If you go to Jharkhand, Chhattisgarh, tribal regions of our country, you'll find 40 to 50% of women will have a BMI below 18.5. And similarly, and very worryingly, the overweight and obese is going up, particularly among women and particularly in urban areas. And so almost the same here, women and men, 25% almost have already become overweight or obese. Anemia has been a problem that we haven't been able to crack, whether it's children or women, slightly less in men, and particularly pregnant women, despite all of the programs we've had. So there's something going wrong there. And probably what it is, it's the lack of dietary diversity. And we'll talk a little bit more about that, because majority of Indians, the diet is mostly cereal based. Of course, water, sanitation are very important. It's not just enough to be able to eat healthy food, but whether it gets absorbed depends on whether you have a lot of infections in your gut. And that in turn is basically safe water and sanitation. So as that improves, certainly the absorbability of the food that we eat, keeps improving, and also there are less worms, intestinal worms. There's now a deworming program and all that. Now, if you look at the NFHS data and look at gaps, and again talking really about starting with birth, you know that breast milk is very essential for the normal growth. In fact, a baby shouldn't get anything except breast milk for 6 months. But again, the NFHS tracks that, and 40% of children started breastfeeding within an hour of birth. That's the standard. 64% under 6 months are exclusively breastfed. It's supposed to be 100%. But more worrying than that is the complementary foods. After 6 months, a baby needs more than breast milk, needs many more calories and other nutrients. Now, adequacy of the complementary feeds, that means quantity and quality, is only 11%. So only 11% of babies in India who are 7 months and older are actually getting the right quantity and quality of food. So no wonder that we see a lot of growth falling off the growth charts at that, starting at 7, 8 months, 9 months, and then continuing, and that's when the stunting begins. As long as the baby is breastfed, they usually grow well. Lack of creches affects both physical and cognitive growth. So many working women have no choice but to leave their babies either with an older sibling or with their some relative or a grandmother or something. And I've seen quite often that these babies are not fed as they should be fed, because babies need to be fed every few hours. But if it's a sibling or somebody else looking after, they'll just give the child something, and that child is chewing on something which is not even getting any nutrition, just to keep them quiet. So I think that the 6 months to 3 years period is when we are really missing the bus. And just one intervention alone, creche, which can provide both nutrition and cognitive stimulation, I think will make a big impact. But unfortunately, both in rural areas and in urban areas, we don't have that facility. The Anganwadis only cater to children above 3. And what they do is they give the mother take-home rations to cook and feed those younger babies. But in rural India, women are not sitting at home. Or even in urban, most low-income women have to go to work. And so this becomes a very huge issue. Similarly, school children, under 6, of course, they are getting some supplementary foods from the ICDS program, and then they're getting a midday meal, but again, the quantity and quality of the midday meal. In many states, it would be mainly, again, cereal-based, may not have adequate amount of protein or, fruits and vegetables. And similarly, women do get something called, again, the take-home ration and nutrition education, but this all needs a redesign. So I think we have to think about our food system as a whole. And food systems, if you look at the drivers, starting with climate change, which is really going to have a big impact. We saw last year that for the first time in many years, the wheat output reduced, wheat yields came down because unseasonal heat in the month of March. Globalization and trade, sort of restrictions between countries, and all of that plays a role. What you can export, what you can import, and so on. The income growth and distribution has a big impact on food environments, urbanization, population growth, migration. So at least if you have a rural, if you're living in a rural area, you have a small piece of land, it's possible that you may be able to grow something in the backyard, but in the urban areas, even that is not possible if you're living in a slum or in a housing board. Of course, the politics and leadership is important, but also consumer behavior. So we have to look right from the beginning and see what we're growing, what our supply chains are like, what are the food environments like, the economic aspects, and then the social, economic, and environment that we live in. I already mentioned that high sodium is probably the one dietary risk with the largest impact on health, and then low consumption of whole grains, fruits, and vegetables. And so this study that was done by the IHME found that just increasing vegetable consumption from 0 to 350 grams per day, again, they do a lot of it is by modeling, but it could be associated with a significant decline in all of these things. And in fact, in other countries which have implemented certain policies, they can show, like for example, in the UK, they implemented a policy of banning trans fats, but also of reducing salt, in the bread and all that, through a policy and a regulatory mechanism. And they did find that it matched up with the reduction in the number of people who were getting admitted with heart attacks. Similar declines can be seen actually for air pollution interventions as well. So, but on the other hand, you look at which grains are being produced, you'll find that it's rice and wheat, again. And whereas if you look at millets, which are also called nutri-cereals or Shri Anna now in India, and pulses, they are more or less stagnating. In fact, area under millet coverage has come down, even though the production is the same, is stagnating. So again, if you don't have the right incentives in place for farmers, you can't expect them to switch from a crop that's giving them assured income just because we say it's healthier, it's better for the environment, it's better for them, it's economics. And so the farmer needs the right incentive as well as a disincentive if you want them to switch. So I think that what is called nutrition sensitive agriculture, but I would even call it agriculture for health. Are we really thinking about, our farmers and the ministries which govern them, the policies really thinking about, how do we diversify our agricultural system? It has to be location specific. Everybody now agrees that growing paddy in Punjab is not the right thing to do, and yet that continues. Technology-enabled learning, I think it's really now today, farmers can get the right information at the right time using digital technologies, and we need to really expand that. Soil health, we've lost a lot of soil health over a period of time, so there's very little nutrition in the soil. So naturally the crops are not going to have those micronutrients if the soil doesn't have. So again, we need to move away from chemicals more to bio-inputs, biofertilizers. And then for fruits and vegetables, it's important to address the issues along the value chain, because very often you hear stories of farmers having to throw away or waste, or there's a glut of tomatoes or a glut of something, and then they don't get the price, and they've taken all the trouble to grow it because we don't have the storage facility, we don't have the food processing capacity. And I think promoting the local use of seasonal vegetables and fruits, this is something that all of us can do, rather than buying things which have traveled thousands of miles, by airplane. At least when I go to the market, I try and see, if not locally, what is grown in India, especially fruits. And I prefer to buy that rather than the imported fruits. but also seasonal. Nowadays we have got used to, because of our supermarkets. Earlier we all, at least I remember, many of you are very young, but it used to be seasonal, so, and we would look forward to those seasons, and you didn't expect to get those things in the other times of the year. So there was an anticipation also of when certain fruits and vegetables would be available. And there was a change. In the summer vegetables, you would move into the winter vegetables, especially in the north. But today we expect everything everywhere all at once, and so that's also a problem. It's not good for the environment. Millets are rich in protein, rich in minerals, dietary fiber, and a lot of phenolic compounds. But again, we have to remember that many of all these nutrients are in the outer layer. And so if you dehusk and debran it and make it white, then you might as well be eating white rice. And in fact, there was a study done by Dr. Mohan's Diabetes Center in Chennai, where they went out and collected 100 packets of millet products from different stores in Chennai. And when they tested it, they found that over 80% of them actually had polished it to the point where it lost all the advantages of eating. So even though you may think you're buying a millet and eating a millet product, actually if you look at the nutrition in it, you might as well be eating rice. So I think it's really important, going back to the looking at the composition and the packages information, and also to ask questions about how these millets are being processed. And one issue is, again, and I've got to know this recently by traveling to tribal areas in Orissa, that these millets need special machinery for milling. You can't just take it to the rice flour and have it done there. So what happens is, in the past, women were doing it by hand, the pounding, and that's a lot of drudgery. So to make half a kg or 1 kg of millets for the household, the woman had to spend an hour pounding it. They've given that up because it's much easier. You get your PDS rice and you can do away with 1 hour of drudgery. So again, there are reasons, again related to gender, related to women's work and time, why millet consumption has gone down. And so today, while some of us in the urban areas have the privilege of buying millets and eating them, actually if you go to the tribal areas where millets are grown, they are not eating them for this reason, that they cannot spend that time in processing it. And just putting simply in these millet machines, milling machines, which we've done through some self-help groups and all in Koraput district and also in Namakkal district of Tamil Nadu, makes a big difference. And those women can not only then consume, but also they sell and they make money. So helping them to add value to their agricultural produce. And again, different millets have different, they all have, of course, majority of the content is carbohydrate. It's not like millets don't have carbohydrate, but they have more calcium, more iron, and again, each millet is different. And jawar, bajra, and ragi are the 3 main ones. But there are huge variety of millets in India, which are again being forgotten. So there's a whole area of work around neglected and underutilized and forgotten foods, which include these small millets, which our grandmothers remember using, but we certainly don't, as well as lots of forest produce and all, which again the indigenous people have a lot of knowledge about, but we don't know. Like if I walk through a forest, I don't know which leaves I can eat and which you can't, but if you're going with a tribal person, they'll tell you, let's pluck these and then we can use it for the next meal. So that knowledge is also dying out. And we are getting narrower and narrower in what we eat. So we've also got this, there are many people who do these nutrition gardens now. So again, that's something MSSRF has done in terms of at the community level, at the household level, but you can also do it in Anganwadi and school campuses. The advantage of doing that is children also learn a little bit about gardening and about what plants give what kind of benefits. And we've in fact put up these gardens in some places, like under the flyover in Taramani, where the corporation has a big playground. We've created a nutrition garden there, and there's labeling so that people, when they walk around, can see which plants are giving them what micronutrients. Similarly, in creches, Anganwadi center, school meals, we talked about how we need to improve the nutritional content, and it can be done actually fairly easily by connecting with local farmers, local self-help groups, etc. But that's easier said than done. Then there are many models of healthy meals at an affordable cost. There's Annapurna Food Van. There's the Amma Unavagam in Tamil Nadu, of course, I won't say it's perfectly healthy because it's quite rich in high in rice and cereal. But this bottom one is quite interesting. It's a mobile teaching kitchen that was done with a project, by this group at Oxford called the Global Institute for Food, Nutrition and Health. What they did is they took, women who are actually sex workers, and then they taught them how to cook nutritiously, of course using their own local recipes and so on. This is in Calcutta. And then these women started going with these mobile vans and selling these thalis, affordable. But at the same time, while you stand there and you're eating your food, they're also talking to you about nutrition. So they also become nutrition educators. So I think that, to me, my mind, is a wonderful model where you're creating a livelihood opportunity, but they're also spreading nutrition awareness. Again, this my plate for the day from the National Institute of Nutrition. It tells you what your plate should look like, and your total fat should be less than 30%, and you should totally avoid saturated and trans fats. Ideally, sugar should be less than 5% of total energy intake, salt under 5 grams, and consume 400 grams of fruits and vegetables a day. Again, this comes from the US. Again, it talks about what you should have on your plate, but it also says drink water, because there everybody drinks a sugar-sweetened beverage with their meal. Then physical activity is also very important. We forget, and those of us who live in cities, it is quite difficult. And I noticed that I was walking so much more when I lived in Geneva. It was very, very pleasant and easy to walk or cycle over there. Just doing your day-to-day, you get enough steps in walking to work and back. Here, in our cities, even if you want to, it is very difficult to walk. Now, physical activity has all of these benefits that are listed there. It's not just about your weight, but it is about mental health and cognitive function and increasing cardiorespiratory fitness. And as you get older, it's really important to continue to exercise and in order to retain your strength in your bones as well as some muscle tone. Most dangerous thing as you get older is to have a fall and fracture, and therefore some people who've continued to exercise are at much lower risk. So the WHO recommends that adults should do at least 150 to 300 minutes of moderate intensity physical activity per week. So that means 30 to 40 minutes a day. Then the other big aspect is food waste. We all don't even realize that 1/3 of the food produced in India gets wasted or spoilt before it is even eaten. And the part of food that is lost from harvest up to the retail level is called food loss, and that's what we talked about, farmers having to throw away things because they don't have storage, or we see sometimes pictures of the FCI go down where there are rats that are eating, or they're being exposed to the rain, etc., and getting lost. But then there's also from the consumer retail onwards, which is the waste that we all talked about, whether we waste food or not. So again, how can you avoid food waste? Plan your meals, make a shopping list, and then also adopt a more sustainable, healthier diet with local produce, etc., and then look at food labeling so that you don't buy something and then have to waste it. Food safety is another important one, particularly since we have a lot of street food in India. It's a huge problem globally. 1 in 10 people fall ill after eating contaminated food. A lot of lives are lost with foodborne illnesses, and especially children, young children, and very often it's from the water that contaminates the food. But nowadays, of course, we also have the issue of pesticide residues on food, so you need to wash it very well. So again, if you don't have access to water, then it's a challenge. It's easy for us to say, do this and that, but it all depends on the environment you live in. There are, policy and regulatory changes one can make. So in schools, for example, definitely both a curriculum on diet and nutrition, and as well as the meal itself that is served in the schools actually can make a big difference. And I think school children is where we have to start, because habits are formed there. A recent study we did in Tamil Nadu showed that adolescent girls between the age of 12, 11 and 15 actually had the worst eating habits. And they were the ones who were eating the most of this, chips and absolute junk food. So that is going to impact their health. They are the future mothers and all that. So if they are not healthy, then it's going to be bad for the future. So I think we have reached a sort of point where this has become a very big problem today, and it's many of these foods are also addictive, because these food companies do a lot of research into the exact ingredients which get you hooked. This is why when you open a packet of chips, you cannot stop, right, till you finish eating the last one. They know exactly the combination of sugar and salt, and we know through science, that it releases certain chemicals in the brain, dopamine, that gives you a feeling of high. It gives you a feeling of happiness. And so that's what you're fighting against, right? So you're telling people to eat a carrot or an apple or a banana. Maybe you're not getting that same feeling that you're getting from your packet of chips or a chocolate. And there are lots of very tempting chocolates outside today. So it's ironical, actually, that this talk is going on while those people are selling. No, but even chocolates can be healthy if you have the the dark chocolates, which have less sugar and are mostly cocoa. Then packaged foods, we can actually, FSSAI can do a lot more to regulate and to also prevent advertising. So you find a lot of processed foods advertised as being good for this, that, and the other, including immunity, build your muscle, this and that. But you look at composition, it's sugar. How do you build muscles with sugar? How do you build immunity with sugar? Actually, they should not be allowed to advertise those kind of claims, which are completely untrue. Regulation on the use of additives. Then when you eat out, again, try to eat healthy. And taxing junk food. So in Thailand, there's a very good institute called the Institute for Health Promotion, which is something I think every country should have, but very few do. And essentially, it goes back to what we were saying earlier, that to promote health, you need a different set of activities than to treat people who are sick. So what that institute does, and it's funded entirely by taxes on tobacco, on alcohol, and on high sugar foods, sugar-sweetened beverages. Those are taxed more heavily, so that it's also a disincentive for people to buy them. And then that tax comes into this institute, which works on policies to promote health, whether it's about road safety or it's about tobacco use, and or about healthy eating or physical exercise. In Thailand, there's a huge amount of sugar and salt in their diet, which I realize because even their salads have a lot of salt and sugar, and Southeast Asia uses the fish sauce, which is very high in salt. So again, it's cultural, and so changing that means that you've got to educate the public based on local. So there are examples globally of doing well. Similarly, food labeling. So this front of pack food labeling, if you have a traffic light system where you could have a red, if you saw a red on the packet, then you would look twice, right, to see what it is. And then you would make a choice, should I buy this or not? But again, the companies are all, don't want this, obviously. So there's a big lobby that fights against this type of labeling. In Singapore, for example, what they did is they had ABCD. So your package is according to the composition of sugar. So they just started with sugar alone, because I think sugar and salt actually are both very harmful. So they started with sugar. If you're C or D, that means that you have too much sugar in the product, and you can't advertise your product. So the company cannot advertise that product. And when the consumer sees it in the shop, they see C or D and they think, okay, why don't I look for something which has an A or a B label? In 2 years, they have found that companies have reduced the amount of sugar in their products, because nobody wants to be in that C and D category. So voluntarily, they've cut down. So there are ways actually of pushing companies also to behave better. Then, of course, we have the huge public distribution system. 800 million people are getting their food from the PDS. So if we could repurpose that and not just fill people's bellies or talk about food security, but rather talk about nutrition security, that means you're going to give them, you have to provide more nutritious things for them, not just rice and wheat today, which is practically free, but millets, pulses, more protein, healthier oils instead of palm oil. We should be giving healthier oils, maybe reduce the amount of sugar that we give. Don't provide maida, but give more healthier options, more proteins, Of course, fortified foods now, the government is fortifying cereals, but again, that's artificial fortification, which is being done by addition of the iron and some micronutrients. And ideally, that kind of chemical fortification, of course, if you have to do it for a limited period of time, you could do it because the whole country, they feel is anemic, and so this is the only way out. But eventually, that's not the way to correct nutritional deficiencies. It has to be through your diet that you get a balanced diet. Similarly, could we think about distribution of vegetables, fruits, and pulses at subsidized prices? It doesn't all have to be free. You have, in many places, these sandays or farmers markets, where farmers can come and sell their produce. Of course, monitoring of food loss and waste and proper storage facilities can really help to reduce the waste, because, as I said, we are wasting 1/3 of what we are actually producing, which is huge amount. So all of that we could, but it needs a little more investment. This is not going to happen for no additional expenditure, because as you eat healthier, we saw that it costs more. And so there would have to be a deliberate effort to do that. So we can talk about behavior change, communication. How do we actually get these messages across to people? There's people trying different things. There's a person I know who's developed a game, a video game on nutrition that he's implementing in schools to see whether games can actually make people change. Children, this is 6th to 8th standard children. Right to food is a human right, and we do have in India a Right to Food Act. But the elements there are availability, adequacy, and accessibility. So we still don't have all those elements that work for everybody. So I think as I conclude, maybe one thing before I conclude is to talk about nutrition and infectious diseases, because I haven't covered that in my talk, and we shouldn't think that our nutrition is only related to these diabetes and heart disease and things like that. So I've, as I mentioned, worked on TB and HIV, and in our research we did find long ago that if you gave people good nutrition, so enough calories, protein, micronutrients, then you could actually improve their outcomes, whether it was HIV or TB. And so for TB, it's a well-accepted fact that people who are malnourished and get TB, they have a higher risk of both death and also doing very badly with their TB. They may not get well for a long time. So if you can supplement them, so the government also has a program where they give 500 rupees to every TB patient, supposed to be for their own nutrition. It's called the Nikshay Poshan program. And more recently, the government announced another program where they ask the public, anyone who's interested, to sponsor a TB patient for 6 months. That is called Pradhan Mantri Nikshay Mitra, I think. So you become a friend of the TB patient, and you give them a basket of good nutritious food for 6 months. You pay for it, basically, through your local TB program. So again, it's a voluntary thing, and I found that in remote areas of the country, though patients won't get it because there's no one there to support, or there's no mechanism to support that. But what was interesting is a trial that was recently done in Jharkhand, and this was published in the Lancet, and it was started when I was still in the ICMR, where by supplementing the household of a TB patient, so TB patient, of course, gets additional nutrition, but this study looked at what happens to the family, and the families of TB patients are at higher risk of getting TB, the household contacts. So if you give every individual, adult and child, additional calories and protein, and this was Jharkhand, mind you, in tribal Jharkhand where malnutrition is rampant, the incidence of TB in those households was reduced by 50% compared to the control group, which did not get that, right? So it was a randomized controlled trial, and for the first time in the world showed that nutrition could prevent TB. Now there's enough data on the other side, which is that by analyzing risk factors for TB, everybody puts undernutrition as number one risk factor for TB. So that was well known, and HIV, diabetes, tobacco, and alcohol. These are the top 5 risk factors for TB. And in India, it's more undernutrition than HIV. If you go to Africa, it's more HIV than undernutrition. But nobody had done a trial that if you make somebody get better nutrition, can you prevent TB? So this trial in Jharkhand showed that. Now, of course, we don't have a good vaccine for TB. BCG vaccine is a 100-year-old vaccine given to babies, newborns, and it protects them for the first few years of life. It certainly doesn't protect us as adults. But here's something which is maybe you could say food as a vaccine, which is actually preventing you from getting TB. Obviously, by boosting immunity, I mean, we still need to do the studies to show what are the pathways by which it is acting. The other thing I haven't spoken about is microbiome and how our food influences the microbiome, which is all the bacteria and that live and the other bugs that live within us. And we have I don't know how many billions, Vijay will probably know, 2 billion microbes in our gut. So we have more microorganisms in our body than human cells even. And so those can be influenced by diet. And therefore there's a whole range of science and research around whether you can change the microbiome. I think Ayurveda probably had those principles because, they classify you for a certain type of metabolism, and then they prescribe a certain kind of diet which suits your metabolism. In scientific terms today, we would say that you're trying to change the microbiome. There are even studies, with fecal transplants. So they've taken fecal transplants and put them, because you're trying to get the good bacteria from one person who's healthy to another person. This has been tried for treatment of obesity as well. A lot of the work is still done in mice, some human trials, but there were safety issues as well with the fecal transplant trials because you don't want the person to end up with a very bad infection. So I think that part is probably going a bit slow, but a lot of work on neurocognitive changes and their relationship with the microbiome and what you eat influences how you feel, etc. So there's a lot of deep science there as well that needs much more research. So I think for all the young people in the audience who are interested in this, there's a lot that's still not known about how nutrition is impacting our health and how we could actually change, even our mental well-being, let alone physical well-being, by changing our diet. And sometimes it's trial and error. And of course, some people are allergic to certain things, or some people are intolerant, like gluten intolerance, for example. But those are extreme forms. But otherwise, sometimes people say, oh, I feel very different, after I've changed my diet, after I've moved from one type of food to another type of food, etc. So there is a lot of science there, which is still being worked on. But I think the message I wanted to say is that really, diet is the most important determinant of our health throughout our life course. Early on in life, of course, it's very important because it affects the baby, how it grows and how well the brain grows, etc. But it's important also at the other extreme of life, old age as well, when we are paying less attention. As you know, older people eat less, they're not able to eat as much. But it's really important that they get the right nutrients and don't become deficient. So I think that whole area is also something that we need to be paying much more attention to. Elderly care is going to become more and more, I think, of a priority for us. So this is just to summarize, what we've just talked about, dietary risks being the leading cause of disabilities and ill health. It does require multi-sectoral action, as we've just seen. Nutrition is something that is everywhere and is nowhere in terms of programming. And so if you look, our ministries are all quite siloed and each one has a certain program of work. Nutrition sits officially within the Women and Child Department, not in health. So that means they're focusing on women and children. But actually, this is something that affects everybody. It shouldn't only be for pregnant women and young children that we talk about nutrition. So I think that is why we have to take that discourse much higher. It does, ideally, like climate change, it should be something that is coordinated at a higher level. I think we do need a fundamental shift in our agricultural priorities and incentives, in our PDS and how we distribute what we distribute as free food or school meals or Anganwadi meals. Creches, I mentioned, for the first 1,000 days of life, addressing women's needs, which have really been neglected for a long time. We need to put equity into all our planning. So we're targeting the most vulnerable and also do it in a context-specific way. Community participation, monitoring, and delivery always improves any program. So that community feedback, digital tools for monitoring now are being more widely used, but I must say that these cannot actually replace what human beings can do. And so you can use digital tools to supplement or to complement, to support what our Anganwadi workers and our Ashas and ANMs are doing. AI also can help, in many ways, but I think it's using AI intelligently that's going to be key. Commercial determinants of health are probably the biggest challenge, if you ask me today, because the kind of advertising and the money that these big companies are spending really are the ones that are influencing the food choices. So we need a massive behavior change campaign, targeting youth, but really targeting everybody. And I'm not sure exactly what is going to work, and this is why it was a question early on that I had posed, but it would be good to have some discussion around that, and I think that's my last slide. So I'm going to stop there. Thank you very much for your attention, and happy to take questions or have a discussion, but I think you're going to.
Thank you, Professor Soumya, for such a erudite presentation. In fact, I would say it's not always easy to combine simplicity with profoundness. And a topic that you covered, which brings science with policy, science with practice, and the macro scenario with the micro, it's not always easy. And I think from that perspective, your presentation was fantastic to kind of listen to and understand a lot of things that we may know or we may not know about it, right? So I think a good round of applause definitely is needed for it. Before opening it to others, I thought that maybe a good idea to kind of put my curiosity to you, because you have also seen these issues from a global perspective, and particularly during this pandemic, you have kind of access to the kind of information and data. And also being part of Swaminathan Foundation, and that which has been working at the grassroots level, your understanding of the issues that comes at the grassroots level, and that also adds value to it, particularly the policies and how it is working and not working. So we have this kind of a tension between, say, addressing preventive versus curative kind of issues that we have to take care of, looking at food versus nutrition, and there is a kind of a limited capacity and limited resources, both in financial as well as the human resources that is required and infrastructure that is required. How do you think we as a country, which is kind of in terms of whatever indicators that we look at, a human development indicator, hunger index, or in terms of malnutrition and stunting, wasting, anemia, from that perspective, if you have to see the urgency, how do you think that we can balance between this and expedite this? It sounds pretty the way, if we are also saying that we are going to a $4 trillion economy and the fourth largest economy in the world, and this is what our position is. So how do you think we will kind of take these issues in terms of urgency as a policy, and are there pathways that we can do it? And 2030 is just 7 years down the line.
So it's a very good question, and obviously not an easy solution, because then, it would have been done. But I would think that if we put people's health first, I think one lesson hopefully the pandemic taught everyone is that if you don't have your health, you don't have anything. Your economy just goes into a tailspin, and the global GDP fell by I don't know how many trillions of dollars. But these lessons are very soon forgotten, and we go back to business as usual. If we could prioritize the nation's health as our number one priority, we want to be a healthy country, which is what we do say. I think we've heard a lot of slogans saying, let's be a healthy country. So if not 2030, 2047, what is that definition of health? We need to define. Yes, we don't want any undernourished children. We don't want people who are anemic. We also don't want the entire population to be obese, as has happened, in many countries in the West. So if we start with that and then say, okay, what do we need to actually get there? Food will be a very important part of that. Where is our food going to come from? What is a projection as to if we project from between now and 2047 as to our yields and our acreage and who's the farmers, what are they growing? Is that the right track we're on, or we have to change track? And then that means changing the policies, and some of them are going to be unpopular because we spoke about incentives that are driving people's behavior in a particular way. Similarly, we will have to make unpopular, we want to cut down on unhealthy foods, and our regulatory system has to get stronger, and we need to come down, just like we're trying to do for medicines, make our pharmaceutical sector, assure that the safety and quality of the medicines we get, we can rely on. Similarly, the food has to go through a similar thing. But then it's also things like sanitation, water, and air pollution, I would say. So I think if we start with health and then see what are the main drivers of ill health, we saw the main risk factors, and how do we address each of them, then work backwards, and of course then investment into those areas which are going to need, whether it's new technologies or whether it's behavior change is going to be, whether it's behavior change at the farmer level or at the consumer level. Yes.
Yeah. I just have one more question before we kind of open it to everybody. I'm a little curious about that as also, because you also presented about the public nature of the health, the nutrition dimension, which is important, and the climate change, which is also impacting in certain ways, one side the health and the other side the food production and agricultural situation. So in that context, keeping this publicness in mind, there are several kinds of things. One is that we know that this whole climate change is a kind of again a public in terms of commons, which is the commons in a negative sense. Basically, everybody will be affected by this. There are also commons, food as a commons in some ways. Like say, we have gathered food in different forms. The village commons are in some ways kind of shrinking. The access to forest and those resources where these commons are there. And then, of course, there are freshwater and marine spaces where we have those commons, fish, and which has been one of the very important source of nutrition that you may agree. So do you think this whole process of the privatization and is also another form which is kind of is anti to this, the access to this food and nutrition, and a process of kind of decommunization that is happening? So can we kind of imagine a kind of a recommunization of food, nutrition, and to resources in certain ways that can play an important role in kind of getting access to nutrition and then to health possibly?
Yeah, you're absolutely right that the direction in which we are moving is making it more and more difficult. And the privatization of everything is making access more challenging. And yes, I do think we can go back. In many European cities, you find that the common areas in the neighborhood are used for small vegetable and fruit. Everybody comes there and has a little plot. At least you can grow a little bit of spinach or your, So even in urban environments, I think it is possible. There are a lot of rooftop gardens now and things like that. But again, people who have the means will find the ways. I think it's the people who have been deprived and who are already living in a very, sort of difficult situation. They are the ones that we have to think of imaginative ways where they can have access. I think whether we're talking about urban poor or also rural, many of them are landless and may not have access. And as you said, forests and other things are becoming out of bound. I think the solutions have to come also, the suggestions from the community. So it's very difficult for us to sit and devise solutions for different communities. So I really believe that listening to them, they actually come out with, the right solutions. So our policy making is not inclusive enough.
Yeah.
And so we don't have the voices at the table which need to be. I mentioned women, but I think indigenous groups, tribals, marginalized population, never at the table. And so there's always somebody who's interpreting their point of view. So similarly, if you have a woman at the table, at least she may think about breastfeeding and, because if you, as a woman, you're probably exposed to the kitchen at home and planning the meal or planning how your child is going to eat and go to school, etc. But if you have the table with only men, your policy making is going to be biased. Similarly, with disability also, we've heard many times that if people with disabilities are not in the room, there are things that don't occur to people who are not disabled, which may be the most obvious thing for a disabled person. So I think that inclusivity, even breastfeeding rooms, I've heard even senior IAS officers say that, even till a few years ago, there were no ladies' toilets on the floor. So even if you're a senior officer, you had to go to a different floor of the ministry to use toilets. So starting with basic things like that, but I think there's to be a transformation in the process of
Absolutely.
policy making.
It's true. I even talk to street vendors, and when not having a toilet access itself makes a lot of difficulty for the women who have been kind of in the space of working. So I think we can take a few questions. We have about 10-15 minutes time. Yeah. And you can just introduce yourself while asking the question. It would
Sure,
be.
yeah. I'm Vijay Chandru from Indian Institute of Science and NCBS. Well, thank you, Soumya, for, I think, a wonderful exposition of food and wellness. And I guess you also touched on food as medicine. But the one topic you didn't touch on is food and illness. So just wondering if you could say something about, for example, food as allergens, gluten and so on, but also pathogens in food. So, spoiled food or just infections coming through food. So, for example, when you think of dairy, I don't want to scare people, but there is actually a reasonable amount of TB that is actually still transmitted, from milk, right? And so I think a recent Penn State study in CMC actually showed a fair number of the pathogens of TB patients who had been hospitalized were actually bovine. So I think, are we doing enough on the pathogen side and food and illness, so to speak?
Yeah, thanks, Vijay. And that's also a vast topic, so maybe can't go into all the details, but there is a clear link between food. I mentioned it briefly about, just mentioned food safety, but whether it's diseases like TB, which hopefully if you're taking pasteurized milk should not be an issue, but there are people who consume raw milk, and yes, TB is very common among cattle in India as well, and we've also done studies to show that you can get TB from cattle, and the cattle get TB from humans, from their carers. So, and also elephants and things in the zoos. So a lot of mammals get TB. And then there's brucellosis and things like that, and a lot of zoonotic infections which could be transmitted through food products. And a few years ago there was also a lot of scare about antibiotic resistance because the poultry that's being fed, a lot of the industrial production of meat uses antibiotics as growth promoters. It's one thing to use antibiotics if the animal is sick, but antibiotic just mixed into the feed in a small amount, what that does is, well, the hope is that it prevents these animals from getting any infections because they're so badly, tightly packed and live in such terrible, cramped environment that the antibiotic is given to prevent them from getting infections. But what it's actually doing is it's spreading that antibiotic. Not just the animals are consuming it, and it may be also in the flesh, in the meat, but also in the soil and the water and the dust around there. So we know that antibiotic resistance, antimicrobial resistance, is a huge problem that's increasing. It's actually increased after the pandemic even more because there was such widespread misuse of antibiotics. So fisheries and meat production uses a lot of these things which should not be used. So again, there's issue of regulation there and standards and actually complying with the standards. So very often also we have standards, but they're not implemented or they're not policed or regulated. So that's also a big issue in our country. And then because of the street vendors, we have so many, making sure that they are providing safe food. But for vaccines, for example, you have a marker that people put on the vaccine case so that when that color changes, you know the vaccine has not been kept at the right temperature for a certain amount of time, and you know that those vaccines then should not be used because the cold chain has actually fallen through. So there are technologies which could be used also to maybe simple things which could be used to see whether a product is still safe for consumption or not. But I think a lot more education, I think your point, Vijay, is about how foods can make you sick, and what you can do, actually, simple things to prevent yourself from consuming food that can make you sick. And then on food allergies, again, I'm not going to go into detail, but yes, they do exist, and gluten is probably the most well-known one. Luckily now there are many gluten-free products that are available in the market, but then some people are also allergic to other elements in the food, and so that's one of the things that doctors will test for if you have symptoms that are not explained by other things. So there is, I think, also an opportunity here perhaps for entrepreneurship to make foods that are needed by these categories of people. There are also inborn errors of metabolism that where there's certain amino acid which is lacking or that you shouldn't be consuming. And so there are specialized foods which actually are as good as medicines in those cases. Those things are not widely available in India, so even though it's a rare disease, the people who suffer from those actually are at a huge disadvantage.
That's interesting. I think HLP, they had this food security definition, which is availability, access, utilization, and stability. In recent, they have added agency as another important dimension. I think that role becomes much more important and stronger as we kind of get into these dimensions of it. So can we take one more question, maybe?
Yeah, hello, I'm Yajat from Azim Premji University, UG first year. So I had a query. I mean, I'm sure this question comes up a lot when we talk about agriculture and sustainability. How hopeful can we be about completely changing our food production to organic and permaculture methods? Of course, not in the near future, but like can we be hopeful for it that we can completely change it?
So I think it also depends on what we mean by organic, etc. Certainly we need to move to sustainable farming practices, which may not necessarily be like fully organic, but they're definitely moving towards more natural farming. And there are, for example, the state of Andhra Pradesh today has already made a plan and they are moving in that direction, and so that's quite an impressive program. So I think if we need to do that for sure. There's no other way, because we cannot go on increasing the use of chemicals continuously. We've already reached that point where it's not having any added benefit and the soils are only getting worse, and we have a problem with water. So this is, I think, goes back to the point of how do we live sustainably with nature. So it's again part of the SDGs, where we don't think of any one thing, but really we have to find that balance. And again, with climate change coming on us, we know that we have to find a way where we can survive, other species can survive, and we're not harming the environment to the point where there's no turning back. So agriculture contributes quite a lot to greenhouse gas emissions. It's about 30%, but most of it is from meat and dairy. But of course, a significant amount of methane is also coming from rice. So I think just addressing all those issues of how you can reduce greenhouse gas emissions, definitely reducing chemicals is going to be one way to do that. So I think, yes, I'm optimistic that we will move. It's not going to happen overnight. It requires a plan, a strategy, and the resources to make that happen.
Thank you.
Yeah, we can take just one more question from one of the students, maybe. Please go ahead.
So there's a huge supplement market, especially in the US. You've seen a huge supplement market come up. In India, I think it's just starting to come, and it's very unregulated, very pseudoscience-y at times. I mean, there are some good benefits to it, but there's also, I mean, there's no information on that. So what is, so I'll give an example. My own family is vegetarian, so typically some sort of protein powder would always help meet our targets. But it's impossible to find out what is good and what isn't. So what is the work being done, at least at the policy level, to kind of regulate this? And I mean, what are your thoughts on the broad topic itself?
It's a very good question. I'm not sure a lot is being done at the policy level, frankly, but I may be wrong. But the whole nutraceutical market is not regulated by the Drugs and Cosmetics Act, and therefore there's a lot of freedom to market anything as a food supplement. So you're absolutely right, and most of the supplements, I think, in the market are not actually fulfilling what they may be claiming to do. So it's one thing to take, a multivitamin supplement, but quite another to take things which are very expensive and which don't give you those benefits. So I think it's consumers really need to be aware, educated, ask questions, pose more questions, I think, also to the producers. And ultimately, yes, I think the nutraceutical whole side needs also some kind of, just like we have the Drugs and Cosmetics Act, we do need some policy formulation there, I think, so that certain minimum standards are set and that you can't just market products with claims without having proven those claims. And this is happening for common things like, even your commonly sold, things which you are supposed to add to your milk and all that for taste. But if you look at the composition, like I said, it's all sugar. Even though the packet may say this is going to boost your immunity, this is going to build your muscles, and the advertisements are all about becoming very strong and healthy. But that you can, if you look at the composition, you'll immediately know that those claims cannot be true with what is actually giving you. So a lot of it is consumer awareness.
Thanks, Soumya. I think we're running out of time, and thank you so much again for this very interesting presentation and conversation. I think with that, thank you so much.